Good evening. Welcome everyone to our WeCare Talks. Before I introduce today's guest, I'd like to speak briefly about the WeCare project. We actually started this last semester online with a meeting with Dr. Rodrigo Brisson. And we have the recording if you didn't watch this yet. And now we continue with this work with the deans. We have created an optional moment for students in the conversation circles to talk about mental health, to inform, raise awareness, and name their feelings. There are many students also who are interested in studying psychology, so they've been willing to understand this topic better. But there's no point in doing this work just with our students and not with the families or with the community as well. So in a conversation with the APA, we wanted to have an informative moment for families as well. And that's how we came up with the idea of WeCare Talks. So the topics were selected by Avenue's parents, by the APA. This is the opening event, but we're going to have others as well. And it's an informative conversation, not just to inform you what is anxiety and depression, but how to deal with it as well. So it's also about discussing strategies. We talked about strategies on how to deal with these moments. We have Institute Ame Sua Mente, or Love Your Mind. Gustavo and Dr. Rodrigo Besson, they're both part of this institute. And there's a phrase on their website that says, knowledge is the best weapon against prejudice. So this is our goal here today. It's to bring knowledge, share knowledge for all of us so that we can deal even better with our students, for those of you who are watching us online as well, so that we can help each other out. So I'm going to introduce our two guests to you, and then I'm going to give them the microphone because they are the stars this evening. Mariana is a psychologist. She's a master in physiology from the Institute of Biosciences at the University of São Paulo. She specializes in neuropsychology from the School of Medicine at the University of São Paulo. She has expertise in the areas of neuropsychology and neuroscience in education. Welcome. Gustavo Stanislau is a physician, psychiatrist from the University of Porto Alegre. He's a PhD student in psychiatry at the Federal University of São Paulo. He's also a clinical researcher at the Program for Recognition and Intervention in Mental Risk States. And he's also a member of the group that studies technological addictions. And he's the organizer and co-author of the book Mental Health at School, What Educators Should Know. I highly recommend his book. So we have pre-selected some questions connected to topics, situations, and demands we've been hearing from families. Whenever we talk to families, we've heard some demands. So first we're going to have this conversation, and at the end we're going to have some time for a Q&A session, also with those of you who are watching us online. So to begin with, I think it's interesting to take a step back, because we say, well, someone is going to the psychiatrist or to a psychologist. Until today, there's still some difficulty in understanding the difference between both professionals. There's stigma, there's prejudice, and people don't understand what's the difference between a psychologist and a psychiatrist. Can you help us with that? Well, a psychiatrist is a physician. It's a person trained in medicine, who has studied medicine. And then we have to go into specialization studies. It's usually a 3-year specialization. And my specialization is in children psychiatry. So that's an additional 3 years of specialization. The psychiatrist has the authorization, legal authorization to prescribe medication. But then we have a problem in our hands. The belief that psychiatrists only prescribe medication, that's their only goal. And that's why oftentimes people don't go to a psychiatrist. Many people come to us and ask me, you're not going to prescribe me a medication, but actually what they want is to have a prescription. I think that today psychiatry and psychology have been walking hand in hand, and together with other areas of science. We do use many techniques that are based on behavioral analysis, cognitive therapy. I have a background also in behavioral analysis, and some psychiatrists can provide therapy as well, but I would say that that's the main difference. We are physicians, and eventually we may prescribe medication whenever this is necessary. Good evening, everyone. So as Tiago said, we work, Gustavo, my apologies, the speaker corrects herself. No, it's because I was just talking to Tiago outdoors. Anyway, so Gustavo and myself, we work together quite often. And it's this very interesting partnership between psychiatrists and psychologists. In psychology, we study psychology for 5 years at university. We don't go to medical school. And we try to understand and work with self-knowledge, trying to understand how thoughts, beliefs, emotions have an influence in people's lives and how we can develop skills and also new behavioral habits so that we can improve people's quality of life, because well-being is a skill that can be trained actually. So this is something quite interesting. We can work, or we can think about neuroscience and neuroplasticity. We can interfere in the way our brain is developing structurally. And we work together with psychiatry, of course. We see to what extent just therapy is enough, or maybe in some situations when we have to add a prescription of a drug plus therapy so that we reach the optimum results for that situation. I have just realized that I have not introduced myself. For those of you who don't know me, I'm so used to talking to parents. My name is Sabrina. I'm Dean of the upper grades, so from 10 to 12th grade. And I have a background in psychology as well. So this is a conversation among colleagues here. My apologies, I didn't realize I hadn't introduced myself. Well, so speaking of these differences, this is something we hear on our everyday work. Well, I have to go to a physician. No. I'm not going to a physician. That's why I wanted to draw the difference. Some studies show that 1 in 5 people have some mental disorder. And 50% of these cases appear before the age of 14. So this information can be frightening. 1 out of 5 has some disorder, and at a very early age, before 14. So based on this information and on these well-structured studies, I would like the two of you to share a little bit about the most common disorders observed in children and in teenagers. So children up to 10 or 12, because in the audience today we have families with children from several age groups. Well, there's something I think it's important when this question is asked. We have to be careful whenever we classify whenever we say, well, at this age bracket we had these disorders, and then we become alert to these types of disorders, and we stop paying attention to other types of disorder as well. This is quite common when we talk about attention deficit disorder, and people, when we say that this is prevalent among boys, and people think that women or girls cannot have this disorder. So we have to be careful with that. The more prevalent disorder in smaller children are what we call behavioral disorders, associated to problems regarding opposition and challenge, and even the attention disorder. There is a peak of cases or identification of this type of disorder when they are around 6 or 7 years of age. That's when children begin having to organize in a classroom, and they have to spend a little bit more time focusing on a specific activity. So that's a period when we see a peak in the identification of ADHD. So the most common disorders in childhood are what we call behavioral disorders. From 10, 12, 14 years on, we have a higher prevalence of anxiety and depression. I am not saying here, mind you, that we don't have anxiety in smaller children as well. Yes, we do have these cases. And when I talk about anxiety, I am talking about this broad umbrella of different diagnoses under anxiety. So it can be generalized anxiety for smaller children, which is quite common. And even we have for smaller children the anxiety of separation. You know, a child who's 8 or 9 years old who feels anxious when they have to be separated from mom or dad. And starting at 10, 12, or 14, that's when we have a higher prevalence of anxiety disorder, depression, and still we also have, of course, diagnosis of ADHD and the other matters that I mentioned before. Well, in my clinical practice, that's also what I see. Smaller children, there are many cases of ADH, and also some cases of anxiety of separation. I think that anxiety spreads around all the cases that I see, all the patients. There's some level of anxiety involved. And moving on, you know, with teenagers, there's a lot of pressure with the vestibular or the university process. They get very anxious and they might develop some sort of depression. That's what I see in my clinical practice. Another thing I wanted to add is that teenagers start having the ability and the capacity to think more subjectively, and that also increases their emotional suffering associated with the idea of death or the future. Yeah, and I think it's interesting to mention that teenagers are more impulsive. So they have courage and they have impulsivity. They are more impulsive. So even the way of showing these things is different. So when we talk about neurologic development, yes, certainly. Teenage years are a very special stage in one's life. Many changes, even neurologic changes, taking place. Okay, so that was a bit of an introduction on mental health. And today's topic is anxiety and depression. This was the most voted topic among parents as a first topic to be approached in our WeCare talks. And as both of you said, there is a prevalence of anxiety and depression. Of course, we all went through a pandemic, but I don't know if this is enough to justify all the cases we've seen. Maybe this was already there, but it became more apparent. So speaking of anxiety and depression, we've always heard a sentence that says, depression is worrying too much about the past and anxiety is worrying too much about the future. We always say, oh, stop thinking so much about the future or don't get stuck to the past. So thinking of that, Gustavo, is this true? Is this what you see in your clinical practice, in your diagnosis? How do you see this statement? Well, this statement sounds correct, but in practical terms, it might not be very precise. There are anxious people who are not looking at the future that much. And there is people with depression that are not stuck to the past that much. So I'm concerned with these labels somehow, you know, these labels that are limiting somehow. And suppose I'm sitting down and I say, well, I'm worried about my own mood. Maybe I'm feeling depressed, but I'm not thinking about my past the whole time. But that's something that happens quite often when a person is depressed. It is common that the person is more alert or attuned to situations the person has gone through and that did not work. It's common. This can be a trauma or an activity that the person conducted and it was not pleasant. So this person usually hyper focuses on something that has not worked that well. So a depressed person, if they are at home too much and they don't have a lot to do and they don't have a lot of future, don't see a lot of future ahead of them, so they are very much attached to what they've gone through in the past. But that can happen in anxiety as well. And this is a very common complaint. Suffering in anticipation for things that are still to come. This is common to anxiety, but once again, folks, let's be careful with these limiting labels about these concepts. Yes, we see many of these labels, of course. Even for us in the school, we have to be very careful, in avoiding these labels because sometimes there's an in-between, there's a gray area. Yeah, and I'm concerned about this because it's been quite common in our institute, people asking us for interviews. And every once in a while we say, no, we're not going to give this interview because people are looking for a label. So suppose there was a case of a boy who gave some shots in a school some years ago. And the interview was looking for the specific characteristics of a person that might get to do that. I understand that people want answers in these situations. But if you are in a hurry to reach answers, you might create more chaos than organization. So if I were to say that a more impulsive person or with negative trends, or if these characteristics fit the criteria, I would be hindering the community. So we have to be careful with these labels. I have a question that's not in our original script, but you connected me to this thought. Of course, when this topic came about and the idea of having the presentations, and we have the Yellow September campaign. So it's impossible not to talk about suicide. And it's connected to what you've just said, the labels, what the press shows. Because people say, well, suicide cases are not in the press or not in the media. Why are they not in the media? Can you tell us a little bit more? One of you, if you could please comment. Go ahead, Gustavo. Well, there's one thing that it's important to know, I would say. And you probably know this already. Publicizing this type of information in a careless manner can lead to a very impactful, to a huge impact. It's the Werther, the so-called Werther effect, which is not an echo effect after one of these events. So I like it when someone comes to me and say, well, this was not in the media. And I feel relieved when I listen to that. Yes, we managed to reduce, because what do we gain by publicizing this in the press? We know it's such a complicated situation. We don't need to cause another source of anxiety. We don't want children to listen to conversations, in the aisles, in school aisles. This is not beneficial to anyone. This is a type of information that we are aware of, but we cannot keep giving this echo because it's not beneficial. Of course, it's common, and when a situation happens, we receive tons of requests for presentations about suicide. And we know it does not work. Having a slide with a lot of data about suicide levels rising up in some age brackets, or this is the second largest cause of death. This type of information, do you believe this is beneficial somehow, or does this provide any type of guidance? Is it a compass for people? We are concerned enough about the topic. We don't need to raise panic. What we do need is to talk about life projects, social emotional skills. We need to talk because people who are connected to these topics are less connected to topics regarding suicide. Do you understand what I'm saying here? Yeah, again, we shouldn't have a Chinese whisper situation about this, not just about suicide, but some people start saying, well, this happened, and one tells the other who tells the other, and then the size of the story grows. And then someone says, well, this is what happened, and the story was not quite like that. Sometimes we get distracted from the fact itself, and that's why we have to be very careful with these events. Yes, there have been principles that were studied to communicate about these topics in the press and in the media. And every once in a while, we see pointless things. There's the series 13 Reasons Why. You probably watched it. And there are many mistakes in that series, I would say, because it glorifies the girl the whole time. It's a girl that through time, she doesn't even seem to show any symptom that might be associated with the act itself. And the worst thing is that they show her committing suicide. They show the method. And this is something that we never should describe. Never. That doesn't mean that eventually we might not have to ask if there is a desire for death. Some research says that when there's the suspicion that this might be going on, this ideation about suicide, the question itself to a young person can be important, and it will not increase the chances of that happening. I think it's important to say that, because otherwise it seems we cannot say anything. That's not what I'm saying here. Yeah, all of us have some connection with a child or a teenager who's anxious, or an adult. Most of all, in our everyday lives, a child or a teenager comes to the dean's room or to a teacher or at home, and they say, I can't stand this. I'm going to have a crisis. I'm going to have a breakdown. The ways they talk about this, they are very different. Sometimes they cry, sometimes they're shaking. There's a physical symptom attached to anxiety. Mariana, what is the first step to help when a child or a teenager comes to us showing a symptom of anxiety? Well, the first thing is always to draw a connection, establish a connection. How do we do that? We have to be present, we have to listen without judgment, we have to empathize. Anxiety and depression, they are a process that involves genetics, environment, relationships, many different things. So it's a process. There's no silver bullet as a solution. So this is something we have to work in order to inform with psychological education, and also talking about prevention. How can we give these children and teenagers tools so that they can deal with the difficulties, with the challenges that will arise, and so that they develop resilience? So back to your question. Yes, we have to listen to what they say. We have this trend of always trying to rush and solve the problem. We want them to stop suffering, right? No, don't worry, everything's going to be fine. But what they need at that point is connection, is to have their pain or their anxiety understood. Even when they have physical symptoms, stomach ache, so they're actually feeling something that is out of their control. First thing then is to listen, to be in sync, attuned to that child or teenager, and have that person feel it and self-regulate. After we connect, we need empathetic communication, and then we're going to start working. There are some tips and tools that we can use. A tool that we all have is breathing. So we can say, yeah, that's expected before a test. We are always more anxious because we get tense with the grades we're going to get. I understand that you're frightened and that you feel fear, because this is a reaction you don't control. If you feel threatened by anything, whether that's real or imagined, you will trigger fight or flight response in your body. And that's why we feel these unpleasant feelings. So it's your body getting ready to either fight or flight, or to freeze sometimes. So to help the person move away from this mindset, that can be, hindering for their learning process, because their prefrontal cortex shuts down at this moment. They don't know what to do. It's as if they are really panicking, I'm breaking down here. So we as adults, we have to help them to calm down. How do we change the switcher, so to speak, the fight or flight switcher? Breathing. That's what we call physiologic sight breathing. Physiologic sight breathing. Many surveys shows that quickly we can help a child or a teenager to go back to a calmer state. So it's you inhale twice and you exhale prolongedly. And that decreases your heart rate, your body tends to go back. So it's as if you're telling your brain, there's no threat here, you're safe. Gustavo, as we were talking about anxiety symptoms, anxiety disorders, and there are so many names and nomenclatures. Can you please clarify these different names? Well, as we were saying, anxiety is a state of alert, and it's necessary for us to adjust to our surroundings. Before we had speech, we needed this alert state to have focus or to organize so that everything works. So this state of alert, it's a baseline moderated state of alert, which can help us to adjust in our everyday lives, to cross a street, to get ready to a test. It can be helpful. But when the state of alert increases, that's when we start seeing dysfunctional behaviors. So a little bit of an alert state is helping me focus on you here. I'm concentrated on what we're doing. If this alert increases, I might want to get out of the seat. I might not want to be here in front of you. So my behavior will look at flight or even fight in some situations. From a cognitive perspective, I might begin to believe that you are judging me in a negative manner, that you are not understanding what I'm saying, this type of thing. So that also makes my behavior be like, I want to leave this place as soon as possible. So here I'm showing you already a degree of anxiety and of alertness that begins to be dysfunctional. It brings suffering, displacement, lower production or lower yield. And if this is preserved for several days with anxiety for over 2 months, we might call this a disorder. And in this period we're going through right now, there are days and there are weeks when we are more touchy, we are more sensitive, we feel more unsafe. That's why we have to be careful to see if this is an ongoing feeling and behavior through time. Because in that case, maybe that could be a disorder. There's something that I think is quite interesting. In communication, we also should talk about our own emotions to young people. Saying, well, I feel anxious too. I feel afraid sometimes. But, let's just go there and see if it works. Yes, you're absolutely right. Everyone is afraid at some point. Everyone is anxious on different situations. There's expectation, and anxiety is normal. It can be normal. It's an adaptive tool. And young people say, I'm so anxious, I'm tense. They come to me and I say, well, you're a normal human being. That's great. I think that it's about learning to manage your anxiety so that you don't reach the point of going into a frequency and an intensity that might hinder your life. So I'm not going to this place because I'm so afraid, I feel frozen. And you were talking about this in your other presentation, and I think it's a great example, by the way. So it's important to constantly talk about these feelings as well in order to normalize them. Yes, because, we cannot feel paralyzed by them. Yeah, so maybe now we could talk about depression or the difference between depression, sadness. Because some students come to us and they say, I don't feel well today. When can it be called a disorder or a depression disorder? And I know this is a huge umbrella as well. That includes many different points until you actually reach depression. So how can we identify and how can we care for these people? Well, we can draw the same analogy, I would say, or the same rationale. Sadness is also an emotional phenomenon that is part of our human experience. So if I go through a sad situation, my brain will go into a sadness state. And there are cognitive functions for sadness. So during a sadness period, my energy level is lower. We save energy somehow in order to deal with that problem. Sadness sometimes moves me away from some situations, which gives us time to think, how am I going to deal with this? So sadness is another natural a phenomenon, and it's important to talk about it. We live in a society where oftentimes we're not allowed to talk about sadness or being sad. However, when we begin when we don't feel pleasure anymore on things, it's as if our brain is not reacting, it's not sending us signs of pleasure. So if I have a dry mouth, I take a glass of water, and my brain emits a sign of pleasure, and that's why I always drink water when I'm thirsty. When I meet a person and we start talking, my brain also emits a little bit of this feeling of the sign through dopamine, and that makes me want to repeat that process. In a depression state, we produce less of these signs. And that's why we don't want to repeat processes that were previously pleasurable for me. So I take a sip of water and I don't feel that pleasurable feeling anymore. So with time, I stop drinking or I stop talking to people. In depression, therefore, we once again have more suffering. In the case of depression, we talk about 2 weeks. 2 weeks in the morning, in the afternoon, and in the evening with these feelings of losing pleasure on things. This is really important to me because it's the biologic side of depression. You know that chocolate cake that you love so much, and you eat it and you say, I don't like it that much. Or meeting a great friend and you say, I don't feel I belong here. So the biologic part of depression is quite important, as well as your perspective on things, maybe having a more negative perspective or a distortion, about things. You constantly think that things will go wrong, or that, these bad things happen only to me and not to other people. It's as if I have a flat tire and I say, well, it only happens to me. Yes, it's always this negative perspective, always foreseeing the worst scenarios. And it's so negative that it draws your attention. Yes, and this is very limiting because, of course, we all say this sometime, But if it's like 2, 3 weeks, 4 weeks, always with this type of limiting negative perspective, that can be a sign of depression. There is a question when you talked about anxiety, saying that this is natural, of course. And we see many people who are functional anxious people. Anxiety actually motivates them and encourages them. Whereas with depression, it's paralyzing sometimes. Do you see functional anxious people in your clinical practices? Yes, I do. I do see a lot of those. Of course, quality of life is not great, but these people are functional. But I would say that they function with a lot of pain, some young people and teenagers. I think it's important to talk about this stage. There's this confusion that oftentimes we have. Teenagers, they feel bored. Their brain changes precisely because they're preparing that person for adult life. So everything that was connected to childhood, they start thinking that everything is boring. They question their parents. Oh, my parents are so conservative. They have these more innovative ideas connected to risk. So there are changes that happen in their brains precisely to prepare them to become adults, so that they want to become adults, so that they want to explore the world and get to know new things. Of course, this has positive sides and risks as well. In this phase, it's really important to understand how this works. That's why I believe it's important to understand what goes on in this stage. What are normal behaviors, quote unquote? Because moms come to me and say, well, my son is in his room the whole day, the whole day inside his room. Are they depressed? Of course, we have to foster them. It's difficult to deal with a teenager because they think they know everything. They have a lot of self-trust, but not very much self-control. So we have to be patient when we communicate to young people. But I really think we can help. This is a phase of life when the brain is very prone to learning. If we know that we can interfere with intention in the very architecture of the brain to develop abilities in them so that they can self-regulate, so that they can be happier and have more well-being. When we are aware of that, we can make interferences with a positive intention. Yes, and a characteristic of people with anxiety, or a possible characteristic of people with anxiety, is that they want to have control over their environment. So perfectionism is common among people, anxious people. Because if you control reality, so if I study more than I have to, for instance, I reduce the possibility of exposing, at least in my own mind, of exposing to some type of frustration. So oftentimes in some schools, we see that the best students in one classroom can be anxious children. They might study more than they need just to have control over that situation. However, when they have this feeling of control, they cannot drop control. And then it's a test that is not really important, but yes, I go on studying more and more than I have to because I need to control everything. Exactly, Gustavo. I have many patients with this profile, and they end up living for their studies or living to get the right grade. And they lose out on their youth years, on the playful social side of being a young person. Yes, they are excellent students. They are A students. But some of them have a little bit of sadness. Maybe they lack on the social side. Yes, we are talking about visible behaviors, right? What are the behaviors you can tell us for smaller children and for teenagers as well? What are the first behaviors that draw your attention that parents can watch to and how to act preventively with children and teenagers? You were talking about the tests, right? Sometimes smaller children, if they don't draw the perfect line in a drawing, they feel tense about it. Is that a sign of something? Maybe it isn't. Can you tell us a little bit? I think that Gustavo can give you the answer, but I think that a good parameter is to think about rigidity and chaos. Mental health helps in between these two things, not too much rigidity and not too much chaos. If you have a young person that everything is rigid, nothing can be, out of place, maybe there could be a yellow light. Trying to relax a little bit with organization. And on the other hand, if you have someone who's extremely chaotic, fully disorganized child, it's also something to watch out for. But I think that Gustavo can, this is something that draws my attention. I would also mention that anxiety is connected to a state of alertness. And that leads the person to react to any type of scenario, most of all, unpredictable scenarios. So a child that does not want to get away from mom to go to school, or they don't want to try new food. A child that never wants to go to a place they don't know. And when they grow up, a child maybe that always wants to wear the same clothes. Because if we change our clothes, we run the risk of being observed. If I always wear the same clothes, I have a certain feeling that people will react the same way to my presence. So being hyper reactive and thinking of catastrophe scenarios or avoiding things, it's important to pay attention to that. But again, it has to be sustained through time. If you watched a terrible show on TV or a scary show on TV, a child might spend a couple of days scared, but this is not a disorder, an anxiety disorder. Yes, and there are some stages in development where they have more of those behaviors. My older son, there was a stage when I thought he had obsessive compulsive disorder because his laces, he would not go to school if his shoelaces were not exactly, similar. And I said, oh boy, we cannot do this. But then it just, changed. He changed. I observed, but it didn't last for long, and I said, well, he's fine then. Yes, sure, there are some behaviors. All of us have maybe had something like that, with children we know and how they changed. Maybe we have some children who were methodical as children, and they might become less organized as teenagers. So, yes, we have to be aware of behaviors that are continuous and ongoing. So, speaking of the first signs and the difference between signs and symptoms, this is really important. A sign is not a symptom. Can you talk a little bit about this? Yes. A sign is an external factor, it's something we see happen. We see, for instance, a child who does not want to be alone, or a child who does not want to try new food, or a child who is very controlling. Because if something is different from what the child wants, they become very anxious. This is a sign. A symptom can be internal, and sometimes we don't see them. So, a child, for instance, an 8-year-old child who is concerned that mom can crash the car whenever mom drives. So the child is constantly touching the mother because they're concerned. And the mother does not understand why the child is always touching the mother. This is a symptom. And sometimes we don't understand this. We think that the child is just being affectionate. But I think it's important to make a difference between signs and symptoms. And when is the right moment to ask for help? To ask for the help of a professional person whenever you have signs or symptoms? Well, I think when it gets in the way of the person's life, when it hinders their quality of life, if it's a child who never can sit on the left-hand side of the car, for instance, or a child who does not want to go out, they have so many rituals, or a child who can never get separated from mom and never goes to school. So when this is something that really damages the person's quality of life, the child's quality of life, in my clinical practice, I always work together with a psychiatrist to monitor for these things. Yeah, and it's whenever we are in doubt or when we are curious, when we deal with good professionals, just one single appointment with a psychologist or with a psychiatrist can be enough and very interesting just to understand what's going on and make a difference. What I'm concerned is that when it takes too long and then the symptoms are there, embedded, going to a psychologist or a psychiatrist office just to learn about our children and how they work, it's not a horrible experience. Sometimes people call me and he says, well, this person is looking for a psychiatrist or a psychologist. I always say information is always good. If you go to good professionals, you are always going to learn something. It's about self-knowledge. I fully agree. I think if you have some question in your mind, ask this question. Maybe just have one single appointment. We do this. Well, this is going on. What do you think? How can I help with this behavior? Because in this conversation with families, with parents, we can look at behaviors and how we can help this child to evolve instead of going into an actual symptom. Yeah, we are talking about the role of the family, which is key. Of course, they spend a lot of time in school with us, and of course, we look at their behaviors. But at home, when they're with you, that's when they're most genuine. And sometimes they're different than what they are at school. Because, when they come to the school, they know that they will be judged by their peers, and oftentimes they behave differently. And it can be tiring to wear a mask, quote unquote, in school. But it's really important, your observation as parents, to inform this whole process. Something interesting happened to me in my clinical practice. The parents came to me, mother and the father. It was an online appointment, and they said, Gustavo, we're not looking for therapy or treatment. We just want to talk about our daughter, and we want to hear from you whether there's anything that we should be aware of. So they came to me saying, we just want to know a little bit more. And it was great. It was really interesting. That girl did not need psychiatric therapy. and I referred her to a psychologist. But maybe not even that would have been necessary. Just a conversation can be so important. Yes, yes, I am very happy when parents come to me just for a conversation because just this information can have a very positive impact in prevention and in promoting mental health at home as well. Mariana, you were talking about techniques. You talked about breathing. What techniques and strategies can we share with parents to deal with this in their everyday lives? It's different from a clinical practice, right? What techniques can we use besides breathing to help? Well, there's a lot of things we can do at home. The family is key for all these processes. First of all, as parents, I'm also a mom. I have 3 children. So I know that theory is very beautiful, but sometimes it doesn't work in practice. So together we have to understand what works and how we can do this. So I think it's important that we, as adults and parents, we also have to be aware of our own internal emotions, feelings. How do we connect to our children? What do we transmit to them? What behaviors do we have that they might copy? Because, living together, of course, creates models of how people work. So the first thing is self-regulating ourselves. I know it's extremely difficult when we have a more challenging child or a teenager in a difficult situation. It's difficult for us to remain calm, right? So that we can connect. Because they listen to us when they feel hurt, when they feel in tune with us. Just speaking when they're irritated, no one's going to actually listen to each other, and no one will benefit from that interaction. And it starts with us, with adults. We have more resources, but I know that being a father or a mother, we learn a lot from our children. They help us to develop. So being open, being curious, listening without judging, being empathetic. Empathetic with your child's age, because sometimes we think of our own age and we are more mature. We think, well, what would I do? Some people come to me and say, well, my son was sad over such a little thing at school. Well, it's little for us as adults because we can find an easy situation for that situation. But for a child, for instance, who's feeling excluded from a group, and a child doesn't have all the resources we have, social, emotional resources, for that child, that little thing might be very difficult. We are part of the neurobiologic development of that child. And this is very powerful. Parents can really start from an early age to help children, to promote mental health, providing them safety, with safe attachment to caregivers. Your caregivers cannot be the source of fear, the source of threat. Because oftentimes we do get mad, we get angry, and we lose patience. And children become afraid. And they have this difficulty in developing this perception of safety. So they are constantly alert. So parents can always be present, be attuned. I know it is a challenge in the world we live in. There are so many distractions. And I think it's about practice. It takes practice. We have to practice being present for our children and for listening without judging. We always try to solve their suffering. We want to solve their problems. We don't want to see them suffer. But, suffering and pain, they're part of the growing process. They have to go through this to know how to deal with these emotions. And also giving them tools, as we said. We can teach them how to remain calm and how to be patient. sometimes it's more difficult for us to deal with these things. We are in a hurry. We have to go to work, of course. But it's important to be aware of that, because if we are aware of how we are feeling, it changes everything. Your behavior has more intention. You know what you're doing. Otherwise, you do it automatically. There's something I listen in my clinical practice from young people. Many of young people who have depression or anxiety, they feel the lack of connection. They feel disconnected. They feel like no one listens to them. They feel like no one validates their emotions. And what do I mean by validating? Well, let's accept what our child is feeling. They're sad. They're upset by something you might not think is important. But let's just accept this. We are not our children. We are different from them. And we have to be integrated to them. We are not the same person. So this concept of integration, let's honor these differences. The differences in age and in characteristics, they develop their identity when they interact with other people, in their family, with their group of friends. And that's how we contribute for them to be able to self-regulate so that they can calm down by themselves. If a child is really anxious, oh, that's silly, don't worry, it will be fine. Or saying, what can I do for you? It's just being there together, present, The best thing you can do is giving them your presence, your attention. Okay, let's stop and think what we can do. So the breathing technique again, sleeping. Sleeping is extremely important. Do they sleep well? What is the quality of their sleep? How long do they sleep for? Because if they don't sleep well, they can be more irritable or more anxious. So I would say the lifestyle, eating habits, movement, physical exercise, all these things that do have an impact in this emotional self-regulation. I have some tools that I can share with you, some apps that I think it's interesting to use with children and you can use with yourselves. So the breathing exercises, neuroscience has a lot of information and excellent results. We can use this information to decrease suffering and to improve our quality of life so that we have less anxious children with less disorders. So yes, I can share some strategies and some apps. There's Healthy Minds. It's a free app. There's Yoga Nidra, Soul's Mind, meditation exercises. Just 1 minute exercise with children with playful strategies. It creates the habit. If we create these small habits of pausing, of resting, of reflecting, of being in contact with our internal worlds, we don't have a lot of emotional literacy. We don't work this emotional side very much. So it takes practice. Otherwise, we're going to ignore this. Otherwise, we fall under the control of the external environment, which can lead to anxiety. We have to understand how we work and how we make decisions. And we can teach this to little children. We can teach them how to be in contact with their internal worlds. American psychologists call this an insight. It's actually having a sight of your inner body or your inner self. How to develop well-being. 4 pillars. Connection, so quality connections. Insight, so this internal perspective. Cultivating your internal perspective. And this goes for adults and children. Purpose, working for a purpose or guided by our own internal values. And finally, attention, presence. These are the 4 pillars. Yes, when you talk about attention and presence, yes, again, validating what other people feel, because sometimes we see someone who's sad and we say, well, they're sad because of that? Why are they reacting like this over such a small thing? So sometimes we do not validate what other people feel. And we sometimes forget that we were that age once, that it is difficult to be a teenager. So I work with teenagers, but I would never go back into my teenage years. I know it's difficult. It is a difficult stage. Lots of transformation going on. So it's important to put ourselves in other people's shoes, being empathetic and active listening. So there's so much talk about active listening. Without stopping to think, well, what am I going to answer? What is the right answer? No, first let's listen without starting to think about the answer. Yes, they do suffer as well. So many changes in that stage of life. They need a network of support. And sometimes we don't realize how much they're going through. Because we can be empathetic from an adult perspective. And we have some resources they don't. So kindness, this kind, empathetic perspective. There's one thing I think it's important to add to this debate. Anxious children, they tend to have parents who also avoid some things. And it's very common to see this. So solving anxiety comes through the experience. The parents get scared when the child is exposed to a situation that will make the parents suffer because the parents are anxious. So there's this overcaring from parents, and then the child does not go through experiences that are the way to help the anxiety be solved. And oftentimes, just one conversation with the family can have a huge positive impact. So parents, for instance, that will let the child go into a field trip or to spend the night at their cousin's place. And just 15 days later, the parents are back and they're happier because the child is happier. We have lost contact with some things that used to be routine. And when we start being re-exposed to these things, they can look like something new. If you're anxious, so taking a test, for instance. If I am a parent with a tendency to being more unsafe, if I help my child to avoid these experiences, that can lead into anxiety. And it's more difficult to solve the problem. It's important to say that because we do see this scenario quite often. Yes, we see that many parents are scared. Of course, there are dangers out there. And I was reminded of a situation that I've gone through with my daughter. I said she was my smallest daughter, and she was out on the sea. She was going to ride on a boat, and there were waves, and I would say, "Don't do this. It's dangerous. Don't go to that rock." And a friend of mine was right beside me, and my friend said, "Let her go, otherwise she's going to be so anxious. Let her do it." And I said, okay. And that's when I realized that I was transferring my anxiety to her. That's why you have to constantly self-monitor. Yes, of course, parents are mirrors. There was a conversation we had in a dean's meeting recently. We were talking about the social skills in children and teenagers. Well, they spent 2 years without developing these skills effectively. It's not that they have not developed nothing, but coming back to in-person school, we saw many students who were happy, but many students were tense. They were anxious. How's that going to be? We were seeing each other online, and now we'll be together on breaks. Will I be welcome? Some children even changed schools during the pandemic. So they stopped developing these skills during the pandemic. So I'm going to ask one last question, and then I'm going to open for questions from the audience and from our online audience as well. Because I know this is a topic we could spend hours speaking about. Well, speaking of anxiety and depression, we're talking also about stigma and prejudice. Because when we say, well, let's see a physician, let's go to a doctor's appointment with a child that has a sign or a symptom, And it's the same thing that if you, I don't know, if you have a lack of breath and you go to a physician. Oftentimes we explain to children and teenagers or parents that if you have diabetes, you need to take medication to control your diabetes. And if you have a mental disorder, you also might have to need medication to stabilize the situation. So thinking about the stigma and the prejudice that exists against, asking for help, we want to create a positive mental health culture, looking at improving people's qualities of life. What is your perspective on this stigma, on this prejudice? There are some studies, and I've seen this in your institute, Gustavo. They show that the stigma can postpone a request for help from 8 to 10 years. So let's imagine a person suffering 8, 10 years until they actually ask for help. Because before that, they were afraid of exposing themselves, afraid of being judged. Well, there are many factors connected to the stigma regarding mental health. We live in a culture that has an outdated vision that a mental disorder is connected to the person's character. It's as if that person is weak, they don't have the strength to fight or that they don't make an effort. If you've gone through depression, you know that it's completely different, or if you have lived with someone with depression. That's not at all what this is about. So people oftentimes do not associate mental health with the brain's working. I talk about my mental health just like I talk about my health as a whole. I have a brain. My brain is exposed to many different situations. Sometimes my brain faces difficulties in dealing with some situations. And eventually, my brain might stop working as it should. And I'm going to make up a hypothesis here. But anyway, I've had a pneumonia, for instance. And I've had pneumonia because I went to a place and my lungs were not working. So a mental disorder is connected to how our brain works. And if we think like that, it might be easier to see a psychiatrist or to see a psychologist. Well, there's also a huge problem with psychiatrists. People take so long to go to a psychiatrist that the psychiatrist ends up having to use medication. And then we create this reality, quote unquote, that a psychiatrist is always for drug prescription. And this is not true. And I'm talking specifically to men. Usually men take longer to go or to ask for help. And we have to change this. There's an additional point which is interesting when it comes to stigma. This connection between children's problems and saying that they are connected to the mother or the father. Oh, the mother is always to blame. Because some people ask me, what do you do? And I say, I'm a physician. Usually I say just, I'm a physician. Well, but what's your specialty? And I say, yeah, I'm a psychiatrist. And then people ask me, well, I think it's a problem to deal with the moms, right? I know what's the impact of that question. That's why many parents do not ask for help for their children, because parents believe that they will be to blame for their children's problems. And many parents do not come to school because they think that the school will blame them for their children's behavior, as if there was a direct proportional connection. Many parents, they feel super relieved when they come to me when I tell them, but you didn't make this decision. This is a 12-year-old boy. He made this decision. And parents are surprised. Well, your son's a living being. They make decisions based on their story. Of course, your story is an important ingredient. But a child's decision is not necessarily the parent's decision. So these are important stigmas. And If we could get rid of those, things would be much better. I have some experience in this contact between school and children and parents, sorry. When the connection between the family and the school is good, the outcomes are different. When we enjoy going to meetings, when we are in conversation, this is always positive. Sure, Gustavo. This connection with the parents. Well, I failed, parents saying, I failed. This is such a cruel thing to say or to think. Our parents, we as parents always wish the best for our children. We always try to do what's best for them. And because of this stigma, oftentimes we don't talk about this. And there's not a lot of information. So just talking to a psychiatrist, to a psychologist, understanding better how we as parents can make a difference, how we can help. I think it can lead to a lot of improvement. And I think we're getting there. Yes, certainly. There's something we always talk to students. Some students say, my mom doesn't understand me, my father doesn't understand me. And I always tell them they don't do this on purpose, your parents. They're trying to do what's best for you according to their life experiences, according to the information they have available. And we are very glad to see when parents come looking for information. Yes, and I always ask teenagers to put themselves in the shoes of their parents. To understand that their parents were teenagers once as well. They have their own history, so they also have to be empathetic with their parents. Okay, I'm gonna open for questions from the audience. We do have some online questions. Are there questions here from the in-person audience? Yes, we do have one. You started this presentation talking about the differences between a psychiatrist and a psychologist. And I have to say that I've gone through a psychiatrist when I had postpartum depression. And I went to a psychologist to do therapy. But I did go to a psychiatrist when I needed medication. And it's as if you were asking for drugs. A friend of mine said that to me. So for children and teenagers, how do we know when to go for a psychologist or for a psychiatrist? I'm going to give you a practical answer. I would always go to the psychologist first because the psychologist will do the screening for you. The psychologist knows whether you have to go to a psychiatrist. Now let me give you a more complex answer. If you notice a risk, a high risk, and what is a high risk for psychiatry? The child with a very strong behavior or a very unusual behavior. Because if the child, for instance, has hallucinations, I know it's very, very rare, but it happens, or psychomotor agitation that's very strong. So that's my answer. If the child, can be in an office with a psychologist, let's go first to the psychologist for a screening process. But if they're not in conditions of going to a psychologist's office, then you can go to a psychiatrist. Yeah, and come to school also. Talk to us here at the school, because we see children in their routine and we are looking at them. We see their behaviors. We can also refer you to the professional, to the right professional. Good evening. Just these days on a WhatsApp group, I received a TikTok video. It was a psychologist talking about symptoms of a disorder. And the moms in the group started saying, my son has this, my daughter has this. And then a father said, well, actually, I took my son to the physician and the school never identified this. So when we think about the symptoms, how is the partnership between psychologist and the school? Why do we expect this from the school? And sometimes we don't even expect this from a pediatrician. Yes, this can be confusing, I know. the school, I think, can refer to a psychological assessment. Usually children come to the psychologist, and sometimes we refer them to a psychiatrist when we believe they need medication or the assessment of a psychiatrist. Sometimes we just want to be in dialogue with another professional. So this partnership between the school and the psychologist, it's key in this path. There's something important. We cannot overload the school with things that are not necessarily under the school's responsibility. There are some diagnoses that come to us, and it takes us months to understand or to know what the diagnosis is. So I'm always concerned about blaming the school, for a disorder that was not observed in the classroom. In my clinical practice, I can ask that person if the person has a desire of death or obsessive thoughts, but a teacher cannot do this in front of a whole classroom. It's a very different thing, the classroom and the clinical practice. But of course, things do happen in a classroom, things that don't happen at home, such as taking a test or fighting with a school colleague. Many things happen in a school that allow those people who are in the school to observe these things and maybe to talk to the family. And if the family has a nice relationship with the school, you might even ask, should we go through to a psychologist? So, my concern is just blaming the school. But there are some things that happen in schools, and schools that are attuned to mental health can help you identify this. But there's something that worries me in your comment, which is this TikTok aspect for mental health disorders. Many people ask me about stigma today, and I think about the fact that people always want to raise the flag saying, I have this disorder, which can be really frustrating somehow, I would say. I think we are going through a moment that will find a solution. I think that young people will have more information about mental health. But we are going through a moment in which mental disorders are being banalized. Some people write on social media, well, my anxiety today has reached 1,000 points. But if you have real anxiety, if you are going through therapy, this can be really frustrating. Well, everyone has this, and everyone can live with it, and they are buying sneakers online, whereas I cannot even go to school because of that. So I'm a little bit concerned about this. But I think this is a moment we're going through, and I think we're going to find a solution for this. I remember this situation, and I was talking about this with Miss Freitas. When I started studying psychology, and I think that some people will identify with that, we buy a psychopathology book. It's a huge guidebook, and we start looking at the disorders, and you keep on reading it and reading about symptoms. And I placed sticky notes in everything I thought I had. And I came to my teacher, to my professor at university, and I said, I have all of this. And he said, fine, because if you had only one sign, I would be worried. All of us have many signs and many characteristics, and we have different personalities. So I never will forget what he said. If you only had one sign or only one sticky note, I would be worried. I'm going to read an online question here. There is a question about how to help a teenager who does not want to have a social life out of school, who does not want to, or who is very solitary. My son doesn't seem to know what to do when there's no prepared screenplay. The pandemic, of course, made the situation worse. Well, we have many cases like this one. I think, first of all, this is connected to Moms and dads, they feel very anxious when they see that their children, they do not have a social life. And a social life can be protective, of course, it's helpful. So first, again, validating, connected to that person, to that young person. I don't know if this boy is seeing a psychologist, but if he's not, maybe he should see a psychologist that might help him to develop social skills. Facing new situations or winning over our own fear. Of course, our fears are our natural feeling, but it can be hindering if we don't face our fears. When we face our fears, we move to new stages in our lives. And oftentimes, this is very much connected to anxiety. It seems to me that this is a case of social anxiety. Maybe this boy is afraid of not being included or feeling included. I see this in many young people in my practice. And maybe having a psychologist to guide the parents. Because this person might not want to go out because the mother or their father is always saying, you should go out, you should do this, you should do that. I know they're trying to help, but maybe it will not be that helpful. So knowing how to help is key in these cases. Yes, and I think it's also connected to each person's personality. Some parents come to me and say, well, they never go out partying. Everyone goes out partying, but he doesn't. Well, maybe that person doesn't like parties. Maybe it's not their profile. Maybe they enjoy doing other things. And for smaller children, in these children's parties that are very noisy, but it might be a quieter child. Maybe for that child, they don't enjoy that. They don't feel comfortable. So it's not just about the pandemic, of course, but the pandemic is important. Just the other day, a mom came to me and said, my son doesn't like to go partying. But, maybe they don't like parties. We have to be aware of that. Yes, that's why I talked about self-knowledge. Understanding the profile, the characteristics of that person. Yeah, if we want to be realistic about that person, maybe the person could be gradually exposed to things that make sense for that specific purpose. I see the two extremes here. One extreme is creating too high expectations. Or maybe a child is too anxious. This is something we have to be aware of, because maybe the person is so alert that the sheer idea of going out of home will lead into a feeling of discomfort. Some child have stomach aches. I think that the rhythm or the pace can be a problem. And what do I mean by this? Is starting to give a faster pace than what the person is capable of facing. So let's go out a little bit more. Let's go to parties. Go to the party. And before you go out, even before the person goes out to buy bread in a bakery, you want them to go to a party. The person will be in a state of alert and they will shut down even further. Yes, you're right. We have arrangements with these young people. We ask, what is it possible to you? Let's think of a gradual approach. What things would you like to do? What things would you like to try and feel comfortable with? And then that person exposes little by little to these situations. And the fear is diminished. We have to talk to parents as well, because parents have to respect the child's pace. Yes, because sometimes things are going very well after a month or 15 days. And maybe bringing a friend to play at the person's home, because in my home I feel safer. Maybe bringing a family member for a play date. And little by little, step by step, creating this relationship of trust with the parents. And also accepting that the person will feel alert when they when they go through a new situation, and they'll adjust. But then they start doing these little things and we get excited and we say, well, now let's go to the party. And the child shuts down and we have to take many steps back and start from scratch again. One last question because we are almost out of time. Hello, I'm a nutritionist. There are many scientific articles talking about the relationship between the gut microbiota and anxiety or depression. 95% of serotonin is produced by the guts. And if you have smaller children, I see that there are children that spend 7 days without going to the bathroom. And we know that there's this connection, between constipation, anxiety, and depression. So for the parents who are here, I think this is one of the things we can work with as a prevention. Most of all, if you have smaller children, we know that they're very much exposed to sugar before their microbiota is ready, and that might lead to anxiety and depression. And in teenage years, that can become more serious. So I just wanted to draw this relation because I think it's really important. Well, I'm going to piggyback on your question to talk about our next We Talk. On November 10th, we're going to have this, and we're going to talk about lifestyle, nutrition, and mental health. This is also a topic chosen by parents. How much that interferes in mental health. Just the other day, someone said, well, banana in our snack again. Yes, banana is a natural antidepressant, so eat it. So let's think about what we eat and about our lifestyle. So yes, that's a great connection with our WeCare Talks from November 10th. And that's what we're going to talk about. We're going to have a nutritionist and a psychiatrist focusing on lifestyle and mental health. So I would like to thank the two of you a lot. I'm sure that it was great for all of us watching. We learned a lot. There are some questions that were not answered about different lines of psychology. And I think there's no rule to that. It's different people adapt to different lines. Sometimes it takes 2 or 3 appointments with 2 or 3 psychologists to find the one you feel comfortable with. You have to feel comfortable. And so it goes with the specific type of personality. You can have psychoanalysis or behavioral psychology. And no psychologist follows one single line purely. We study so much, we add new things to our practice. We study different pathologies, so there is a lot of things involved. Thank you all very much.